Welcome back to Data Nerds. It has been a little while since we had our last actual Data Nerds. We didn't have a whole ton to talk about, but now we do.
Yeah,
So,
we got data.
Pat, yeah, Pat, take it away. Let me actually bring up what we were talking,
Let me see
what
the
you want to
data.
talk about. Okay,
Reveal
so
data.
boom. I think I got that like as soon as you said data.
So, for anyone who is listening, audio, not visual, what we are looking at is again some isometric data from the HUMEC norm presented by CSMI. We are not actually sponsored though. It's just what we have. But hey, if CSMI wants to get us something, I would gladly speak on their behalf. Um, So, yeah, a little background on what we got going here. It's the knee, go figure. We'll get the shoulder back going here soon. But interesting case here. So, this is a patient that I've been working with for probably around 7 months now, 7 or 8 months.
Dang.
Um, they were a patient of my coworker who sadly left last summer. And so I, working Saturdays with my coworker, brought this patient onto my caseload, and they were, or I guess are, a post-op isolated ACL with quad tendon autograft. If you're looking at this visually, I think you can figure out which one it is. Um, but anyone listening, it's the left. So when did this person get surgery? This person got surgery in December of 2024. So quick math, that's over a year ago. Um, a year and some change. And if looking right at this graph here, we would see right off the bat that our two isometric slopes are not really close to each other at all. Um, Now, be it that this person is a year out, you know, by quote unquote like normal standards, this is very, very behind. Um, I think obviously each case is exactly that, their own case. And this patient had some difficulties for the first 2 months of rehab. Um, Very hard time regaining full range of motion. Uh, was very stiff for a very long time. Was not very tolerant to much loading. And then continuity, sadly, was quite turbulent just from switching over period, and then also sensitivity of like graft site symptoms and just like total knee symptoms were quite high, and so it was quite challenging to get pretty consistent with loading, and then with glorious insurance. And this person had very extended rehab. It got near October of this past year, and this patient sadly had to go on their own with a provided HEP. But I'm glad to say that
Man.
amidst all this, we are now starting to get some very good progress. The patient themselves is feeling very good about kind of the trajectory of things. This patient is also 44. Um, and in terms of like what are we trying to aim for, this patient just wants to get back to like jogging and some unrestricted like gym activities. So no like extreme sports, no high level like recreational sports per se. Um, just wants to be able to engage in just what we might say as like normal gym going behaviors. Um,
Can I interject something quick? I'm just curious what helped with the turning point for like the trajectory to actually go back on track. Like what were you doing? Like what did you
yeah,
change?
yeah. So, um, I guess let me throw something in here also because this is part of that turning point. Um, 138 days ago, So what is that? That's
It's
that's a lot of
like four
weeks. That's like
months.
20 weeks
That's
almost.
yeah, it's like 4-ish months ago, 4.5 months
Yeah.
ago.
This person got an arthroscopic, like pretty much a debridement done. This person was having a hard time getting full range of motion still, and they decided to go back under to get a debridement done arthroscopically, and then came back and resumed PT. Um, and it was interesting. There was like a few sessions where I saw them and then they kind of just went away. Then they came back, got this procedure done, and then they came back and got very consistent on PT. And then we had that little time block in like October, November, and then the new year came, and now we're very consistent again. And what the turning point was, um, is just like I feel like you hear it from anyone who's a great PT is just getting down to just basics and just really doing what is most important at that time, and not getting hung up on time frames. So be it that this patient was still having a hard time accessing total knee extension while weight bearing and like good knee extension control. And like what I mean by control, because sometimes I think like that whole like motor control thing can be kind of like thrown out just to like compromise for whatever
Just to sound fancy.
bogus. Yeah. What I mean by that is this person, while walking, was inconsistently accessing full knee extension and would walk around on more of a bent knee position, even though passively they can get to neutral or a little bit of hyper, and can show me on the table that they can access a little bit of neutral to hyper as well. So a lot of things just working on, hey, I just want us to work on, can we get straight knee position while weight bearing? Because right now, you're still having problems with that. And I don't want this to then impart any more problems on the graph that, at that point in time, hopefully wouldn't have any developmental laxity, just from time frame of it all. But then again, if you're walking around in a bent knee, I would not want to develop some kind of like flexion contracture or quad or patellar tendon problems. So that
Hmm.
was number one. They're doing very great with that, which is awesome. And then supplementing some really heavy like deadlift patterns and calf raises, and then leaving all real quad loading for knee extension machine. And
Mm.
reason being is because, as you can see from our isometric, this person is only kicking out 40% of their body weight isometrically. When I had this person try doing isotonics knee extensions, like however many months ago, probably like 6 months ago now, um, they could not even do a single rep. So where I took that as, okay, you can't even isolate your quads at like the lowest weight possible. And it wasn't even so much that like it hurt. Like, yeah, it was a little sensitive maybe for the graph site, but sh she literally told me I cannot move this. And so taking it even further of a reductionist, I said, okay, quad loading, closed connect chain, I'm going to anticipate that it's either not going to go that deep because you don't have the strength to do it. You're going to compensate every way possible. So like, why am I wasting my time? We transitioned to a good like 3 months of just doing holding ISOs, for a prolonged period of time, just at whatever holding tolerance they had on the day. And this patient now came back to me this past week and told me that for the past month, they've been able to do isotonics on the knee extension with 10 pounds. And then this past week, they accidentally did it with 20 pounds and they didn't even realize it because they had the weight stack thing incorrect. And so it's just, I guess, like what I'm trying to say from this is this person is feeling progress in like functional things. Like they tell me that they're feeling better. They feel like their recovery from like workouts is getting better. And it's all just from coming down to fundamentals and not getting hung up on like, I need to do isotonic work. I need to do such and such work right now, and just recognizing that this person has such bad inhibition from the two surgeries and such weakness that, if we have to start at a holding ISO for so long, like that's fine. And it's paying good dividends now since about a month ago, I told this patient to do a max ISO just like off the cuff on a training day, and they only got to 50 for isometric knee extension. And on the day of testing, they got 74, which is a new PR for them. So that was huge. So yeah, that was a long-winded answer to your question.
It's all good. Yeah.
Um, so yeah, so isometrically, um, for people who don't know, this just means that this joint angle is held at one spot and this person is kicking out as hard as they can for 5 seconds. They get around 15 to 20 seconds of rest in between each. Is that really short? Yes. Do I do it because of time constraints? Yes. Um, so I always test their involved side first. So left side went first, then the right side. And I always look at the best rep because if I'm looking for their peak, I want to know what the peak is, not the average of said peaks. Um, if people are looking at this visually, you'll see at the right side had a very weird curve. This was a testing mistake. The patient just started the rep, and then they recognized that they just started it, apologized, and then immediately started going again because I said no, just keep it going. um, and yeah, so anyway, values we're looking at, we got 66% body weight on the right, 41% body weight on the left. Qualitatively, if we're looking at these curves, the right side has that very nice, super steep curve, while the left side has that more gradual base curve. All are pretty similar. So COV is pretty nice on these. For people who don't know, coefficient of variation just means are your values super widespread? And if the answer to that is yes, then the actual data that you collected maybe isn't as sensitive as you would hope. Um, but if it's super tight and your COV is pretty low, then it's like, hey, these all look really good. You can use this. Uh, Now, COV does not capture if your test is actually good based on setup or execution. It just tells you that your numbers are good. So, um,
Yeah. I have a comment and then a question.
hit me.
Um, Comment is like even her uninvolved side isn't like particularly great percent body weight. Like I would look at that and be like, man, that like we really got to work on that too, even though it's the uninvolved side, right? So that's also why we don't always use LSI, right? Because like one, it's not the greatest LSI in the first place, but it's also like the right side is fairly weak too. So why not like we want to get both of them up to like higher percent body weight,
Yeah, exactly.
closer to that 100%. And then my question is why, and maybe, I don't know, why the joint angle of 70 degrees? I guess I'm normally doing 60 degrees. So I ask why 70.
Oh, that's a great catch. And I'm so glad you asked. Because after compliance is taken up, I find that these people are actually more at 60. Um,
Mm,
so yes,
that's what I
based
figured.
on
Yeah.
based on printout, it says I'm doing this at 70 degrees, but based upon testing and my eyes looking at this patient, um, I've had it to where I get people in 60 degrees and I kid you not, they are damn near like 30 or 20 degrees of knee
Yeah.
flexion.
Like
Like
pretty
they take up,
extended. Yeah.
well, yeah, because they just lift their hips up from the chair, no matter how tight I sink them down with the seatbelt. They lift their hips up and then they push all the foam of the actual,
The
apparatus at the
pad
end.
down. Yeah.
Yep. And they just kind of do this double fulcrum that almost straightens out the whole knee. So I bring my patients down to 70, um, just because it keeps them a little bit deeper towards like that better muscle length tension. Um, and also I find that it's harder to compensate the deeper you are. Um, I honestly like 90 might be even better, but 90 also could potentially really piss off some tendons. So, but
Yeah. Yeah.
yeah,
That's what I figured, but I wanted to double check on that. Like just thinking there'd be at least 10 degrees of compliance.
yeah, no, exactly. So that's isometric, building up, but still have a lot of foundational work to kind of hit on.
Yeah. So now isokinetic.
Oh yeah.
Boom.
So for people who don't know, isokinetic is movement through a set range of motion at a specifically set speed. So with this person is going from 10 degrees of knee flexion to 90 degrees of knee flexion at 60 degrees per second. How we do this is you get 3 times up and back. Both are concentric. So concentric knee extension, concentric knee flexion. And you have to kick out and pull back as hard as you can for those 3 reps all in a row. And so for our audio listeners, you
Can
will
I also
see.
just interject one thing
Yeah, of
question on
course.
reading this? Can
Yeah.
do you is the only way to know the range of motion just by the bottom of the curve here, like the bottom of the graph where it's degrees, like where it's
Uh,
10 to 90?
yes,
Or do
I
they
believe
say that
so.
somewhere else? Okay,
No, I believe that is the only way to know.
cool. So
Yeah.
sorry,
Um,
continue.
so so if we're looking at the blue lines, that's the right side. Got that normal looking curve to where it's peaking right between 60, like 50 to 60 degrees of knee flexion. And then hamstring is peaking right around that like 30 degrees of knee flexion. And then if we're looking at the left side, the hamstring one looks just like the right side, except just a little bit lower. But then the knee extension is pretty flat.
Oof.
If it literally like flattens out right at 30 foot-pounds, I think.
Yeah. Yeah, right about there.
Yeah. And so looking at that, that is something that we would want to improve upon, right? I would want it to look more like the right side where it has a very nice peak around that 60 degrees and then that more gradual slope down when getting near 0 degrees. But why do I think this is? Based upon what I saw isometrically, I would anticipate this result, but I still captured it just to see where are we at qualitatively and quantitatively. And my idea around this is when looking at the isometric, we can see that the slope is very gradual. That tells me that this patient's ability to generate torque is much slower than it should be able to produce that normal curve like the right side is. Reason being is because unlike isometric, to where you get the whole 5 seconds to hit a peak torque, on the isokinetic, you only get that sliver of time at that one spot throughout the range to try to hit your peak, right? Now, granted, there is some build, right? Like when you're going from 90 to 60, your length tension should be improving. So there should be some, like maybe a little bit of a improvement. But again, if your ultimate capacity, your ultimate quad strength isn't there, you still have some inhibition, and then you pair that up with the actual like rate coding of that muscle, you're just not going to be able to exceed like your almost like ceiling, right? Like you are not going to be able to go above what you have for torque generational capabilities uh, at that speed. I think it would have been fun and interesting if I did this at like 30 degrees per second and to see if with a little bit of a slower curve, can this person make a little bit normal, right? Because
Mm,
I would anticipate
yeah.
the faster it is, the worse this curve is going to look. But
Yeah.
I would anticipate the slower it is, the closer to quote unquote normal it would get as well. Um, so yeah, like
I'm
nothing
just
really
gonna look
else.
right back at the isometrics too, just to remind myself. So in theory, her peak is 74.
Yeah,
So this she could, if it was slower, it could be like she builds up to 74 at that like 6 degrees and then comes back down
right. Yeah,
in theory.
yeah.
Cool.
So, and if you also look at the, can you go back to isometric?
Hmm.
So it almost takes them 2 seconds even just to get to peak, like 2 to 3 seconds, just
Yep.
qualitatively. Um,
Yeah.
and then so the whole test for the isokinetic in that one direction is less than 2 seconds, right? Because it's 60 degrees per second throughout 80 degrees. So yeah, like there's no way
Math.
you're gonna be able. Yeah, that's just math right there. Uh, so yeah, that's kind of my thoughts around why I'm seeing this torque curve. Um, Mike, do you have any other thoughts around that? Any other questions, comments?
Oh, yawn. Not on the quad one. It's interesting to see that the hamstring is still lower. That's not necessarily unexpected. It's good that the curve looks nice, but it's like that's just further confirming too that you like can't forget about the hamstrings in this as
Exactly.
well. What was her graft again?
Isolated. Sorry, the graft was quad auto,
Quad.
and
Yeah.
they only
So like
did
that's
ACL.
yeah, that's why the hamstrings are still like relatively fine.
Yeah. Yeah. So I think what we're seeing from that is the accumulation of just like total deconditioning of that limb just from like a
Yeah.
year plus of turbulent kind of consistency and such. Not for the patient's fault, right? Like there was a whole mix of things for why that was, but um
Yeah.
yeah, in any case, that's kind of what we're seeing and kind of where do I take this data? Because, that's the greatest question, right? Why do it unless you're going to do
Yeah.
something with it? Don't
Yep.
don't just do it just for fun. Kind of still hammering just the basics, sadly. Well, not sadly. Let me take that back. I'm not sad about it. Um, it's good to have a
She may be
plan.
sad about it.
Yeah, yeah, she might be sad about it. But actually, I think she's kind of pumped because I think she's really proud of herself to now be able to like actually move the knee extension machine single leg. I think for her that has been like such a huge accomplishment that it's nice that like although the actual like quote unquote stage of rehab hasn't changed, what she's able to do within that stage has. So she's getting like little crumbs along the way of achievements, which is really great, right? So
Yeah.
um, so yeah, essentially still just gonna hammer quads, still gonna hammer deadlifts, still gonna hammer calves, and then kind of just retests in a few weeks from now and go from there.
So I have a question on like timelines for this. So obviously she's what 15 months post-op essentially, and
Yeah,
things have been turbulent. But so you would expect like, some a lot of athletes would be like fully returned to sport at this point, assuming like just purely based on time, right?
yeah.
What what time, if you compare her to a normal or a more typical progression, what timeline do you think she's at currently? And then second, like a follow-up question to that is how long until you think she's back at full clearance too?
That's a great question.
I don't expect a like perfect answer to
Yeah,
this. It's
no,
all, it's all
I
guess.
was told I'm pulling this from the deepest cranium deepest groove in my cranium. I once heard that a standard, or not standard, but like a typical progression of torque is around 10 to 15 foot-pounds per month. So that's if, consistent training. And of course, that could go up quicker, right? Like
Yeah.
that can go up higher if it's more of a neurophysiological rather than a true muscle capacity, right? Because I would anticipate it to go up quicker if it was maybe more neurophysiological than just straight muscle. Um, just because true strength takes like, the standard like 6 to 8 weeks and all that stuff. But um, so if we're going based off of just those numbers, right? And then they were at 70, uh, 74 for isometric.
Yeah.
So that'd be one, two, three. What? That'd be another five, 5 to 6 months maybe of just doing what we're doing, unless things really escalate really quickly for them in a positive fashion. Um, and then from there, you know, returning to returning to plyos that are going to be more around what they hope to get back to, right? Like, I don't know if doing real deep tier, like split squat isolations or oscillations is something that they need or want to do, right? Like, it sounds like this
Yeah.
person wants to be able to just go for a jog, which, if they're depending on pacing, don't need much deep knee flexion angles. So probably keep things to see, go through our counter movement jump, go through our pogos, go through some like drop lands and stuff, so to make sure that there's some good actual eccentric capabilities that are appropriate for their goals. But total timeline, like, I would anticipate probably another like 8 to 9 months, right? Like, you fulfill strength capacities and then have to monitor the plyos accordingly and make sure that, you're not skipping steps and such. So, yeah, off of
Yeah.
my off of my just pulling out of my ass guess, I'm gonna say 9 to 10 months more.
Yeah, see, it's a really interesting question to me because you would think like potentially X amount of time given the typical progression that people have, but she's already like way delayed too. So does that like lengthen the timeline more? Is it like, the faster timelines for people like they could get back to symmetry in 3 months and then they could return to play in 6 months from now. Well, potentially, but she's probably not on that timeline. So then maybe we just got to like add time to all of those. Like maybe we
Right.
add 3 months to all those. So then it's six
Yeah.
months and 9 months to fully get there. So
Yeah,
yeah,
exactly.
and that's honestly what I would like. I mean, obviously she's your patient, but like I'm sure she's wondering that too. If you guys haven't had this conversation, and that's I think I would tell her on the longer end of my guess too, just to not get her hopes up, to not be like, "Oh, yeah, because 'cause we're finally starting to see progress, you're progressing," like, we don't need to worry about tissue healing, right? Which would limit someone that can, like, produce this amount of force at
Right.
3 months, right? Because we still gotta wait for graft healing. Your graft is fully healed, so maybe we can be quicker than that, so maybe it's gonna be more like 3 months until fully symmetrical, and then we can get to, like, more return to higher level function in, like, 6 months. I mean, that's a totally viable rationale and why I wanted to ask the question. Um, but I think I would tell her like, yeah, given how slow things have progressed so far, like, yeah, we don't need to worry about tissue healing, but now we got to worry about all the atrophy that's happened in the past
Yeah.
year and a half. So let's
Yeah.
Let's just bank on it taking a long time, and you just got to like grit through this.
Yeah, exactly. So definitely adds another, what am I trying to say? This case adds another one to the list of, hey, sometimes these things take longer than anticipated, especially when there are some little bumps along the rehab road, right? So, um, doesn't mean you shouldn't have a plan. Doesn't mean you shouldn't continue to verbalize that plan. I think that's been like the biggest thing for me with her is, every month or so we always discuss, and she's also very uh inquisitive on her rehab. Now to be fair, I think a lot of the times she'll ask me a question and it's one that maybe I gave an answer to 2 weeks ago, but I'd rather have her ask it than
Yeah.
her just kind of live in
Yikes.
this. Yeah. And it's fine. I don't mind because yeah, like I want to keep this idea in her head that like, hey, like, no, you're doing all the right things. We're seeing progress. Let's just kind of ride this train, right? Um, so yeah, like to what you're saying, just because your timeline is quote unquote like away from normal, um, doesn't mean you shouldn't still just go by your plan and have your criteria set and continue to
Mhm.
verbalize that to then instill not just confidence in the patient, but have the patient instill confidence in yourself, right? So,
Yeah.
mic drop. Boom.
Yeah, dude. Well, cool. That's I feel like that's a great time to wrap up. So, if you have listened this far, please leave a nice review on Spotify or Apple Podcasts. If you're watching on YouTube, thanks. Subscribe for us,
Go
and
smack
follow
that
us on
subscribe button.
and
Boom.
follow us on Instagram
Boom,
at
boom, boom,
Reading
boom.
Rehab Pod. Thanks.